Hello everyone. Hello everyone. This is our dental talk without secrets, where we're going to be discussing things that happen in our everyday practice. The first topic that I chose to start this series of presentations is regarding a question that comes very often in our practice. Watch this video here.
Então, aí, João, tá vendo aqui, ó, o antes e o depois.
I'm showing her, the before and after of her treatment. She liked it very much.
E doutor, quanto tempo
Then
dura
comes
a
the
resina?
question. How long will these restorations last? What do you answer to your patient? Okay, in order for us to answer that properly, we have to understand what are the causes of the failures that might happen in these aesthetic dentistry procedures. Okay, in this case specifically, we will be talking about composite restorations, anterior and posterior composite restorations. Okay, and not just why they happen, but especially how can we avoid them from happening? What can we do in our everyday practice to avoid these failures? Okay, so this is a paper that we have published recently this year with Professor Rafael Moraes from the University of Pelotas here in Brazil, Federal University of Pelotas here in Brazil, with the Radboud University I was going to say Holland, it's not Holland, that's in Brazil, in the Netherlands, with Professor Bas Lumans and Professor Nick Opdam. And here we discuss the clinical performance of resin composite restorations. It's like a study from the recent papers regarding, how long and why do these restorations last, and why do they fail? And an interesting thing is that anterior restorations survival rates are comparable with those for posterior restorations and anterior restorations, meaning, they're more or less the same, okay, the survival rates from these old restorations, although with different failures characteristics. And resin composite restorations may fail clinically. This is very interesting, due to the same reasons that led these restorations to be restored in the first place, which is caries, fracture and or wear, and in the case of anterior restorations specifically, aesthetics, because many times the restoration doesn't have any caries, they aren't fractured, they aren't worn, but they don't look well. They don't look nice. So aesthetics is compromised, and that is a very personal input. It depends a lot on the sense of the patient, sometimes on the dentist, and this is very often the cause of replacing an old restorations, even though they haven't failed from a functional point of view. Okay, and for posterior restorations, it's mainly, and for posterior restorations, it's mainly just caries and fracture and or wear. The aesthetic problem is not very important in the posterior cases, okay? There are some risk factors, some factors of risk that will impact the longevity of these restorations, either anteriors and posteriors. And these risk factors are related to the patient, to the tooth of the patient. They are related to the materials that were used, and also to the professional, to the dentist. Let's see each one of those factors separately. Okay, let's start with the materials. Within the past years, there has been a lot of changes in dental materials. We all know that. But the reasons of failure regarding materials, maybe it's more related to the use of the adhesives. The first adhesives that we had on the market were the so-called total etch adhesives. And the 3 steps total etch adhesives. These adhesives, they had the three steps, of course. One was the conditioning with phosphoric acid of enamel and dentin, and then you would apply a primer, and lastly, you would apply the adhesive, properly adhesive, the hydrophobic adhesive resin, okay? Then we had a simplified version of this total etch adhesives, which was this two steps adhesive, which means just one bottle, where the primer and adhesives are all together in just one bottle. And then we have also the self-etch adhesive, where ideally you wouldn't need to use the conditioning with phosphoric acid. So you would use, in the two-step self-etch adhesives, a acidic primer, and this acidic primer would condition and also would allow the monomers to penetrate the tooth structures that were partially demineralized. Okay, and then after that, you would have the second step where the adhesive would be placed. So the self-etch adhesives ideally wouldn't need to be using the phosphoric acid for conditioning, but we know nowadays that for enamel it's very important, and this will impact somehow in the longevity of our restorations, especially avoiding marginal staining that may be leading some dentists to imagine that that is a microinfiltration or something like that, okay? So today we understand that using the self-etch adhesives, we need to condition just the enamel with phosphoric acid, then we wash, we dry, and then we apply the acidic primer, and after that we evaporate the solvent, and then we apply the adhesive. And so this is this two-step self-etch adhesive. And then there were a simplified version, which is the one-step self-etch adhesives. The first one-step self-etch adhesives, they were very hydrophilic and they didn't perform well. But nevertheless, to this day, we still know that total etch, 3 steps, and self-etch, 2 steps adhesives are the best ones that we have available on the market. To use them clinically, we know that we have to consider several steps very closely. We have to be very careful, to start conditioning just the enamel first, and then we apply let me stop here a little bit. And then we apply, as I showed here, we start conditioning with phosphoric acid the enamel first, and then we apply it on the dentin. We count the time specifically, okay, 15 seconds, and then we wash it all out. Okay, so it would be somewhere around 30 seconds for enamel and 15 seconds for dentin. And then we wash it out. We leave the dentin moist. This is very important. We apply the primer, in this case here, Scotch Bond multipurpose. And then we evaporate the solvent, very important step, and then we apply the adhesive itself. After that, we thin it out a little bit, and then we polymerize, and then we go on with our restoration. Okay, with the self-etch 2-step adhesive, what do? We start conditioning the enamel, just the enamel. First, of course, we have to clean the tooth. We have to do our prophylaxis. This is very, 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 very important. And then we will start the selective etch with phosphoric acid just on enamel. We wash it out very thoroughly, and then we dry it. We can dry it without desiccating too much, but we can dry it, and then we will rub the primer, the acidic primer, in this case here is a clear fill, and then we rub it a little bit for, let's say, 30 seconds, and then we will evaporate the solvent, apply the bonding agent, thin it out. We can use a very short and clean blow of air, but we can also use our a suction point, a very small suction point, and after that we polymerize, and then we will start and finish our restoration. Okay, so these are these procedures, they have very important steps that have to be followed very carefully in order to succeed in using the adhesive in a proper manner, and have guaranteed that your restoration will last as long as possible. Okay, so but you don't have to try to understand what I'm saying. You don't have to believe in what I'm saying. What you have to do every time you buy an adhesive, even if it's the same adhesive you have been using for such a long time, always do this. Always read the directions that come with the adhesives. Always do that, okay? And I don't mean to read, just that the paper with the pictures and everything. No, I mean the long paper, with all the details. You have to read that because it's a critical procedure. Applying the adhesive is the basic of your restoration, and it will ensure that your restoration will last the longest possible. So read the directions, okay? And regarding, once again, the adhesives, we know that the gold standards are the 3-step for the total etch and the 2 steps for the self-etch. The first self-etch, 1-step self-etch adhesive that came to the market, they didn't perform well, as I said, so they're not used anymore. And these 2-step total etch adhesives, why do we use them? The question is this simplified version of the total etch adhesive so fast to be using? And even though they have a lower result, a worse result than the 3-step total etch or even the 2-step self-etch when you use the selective etch on enamel, why do we use them? Okay, so this is an important question. Let's try to use the best adhesives that we have available on the market. Okay, today we have the universal adhesives that may be used as a total 2-step total etch or 1-step self-etch. These universal adhesives, they are better version of those old adhesives because of the properties of their components. So these universal adhesives, they're a promise for a simplified adhesives. So if you're going to use it, use the best one you can. I still use the total etch 3 steps, and when the cavity of my restoration is very deep, I use the 2-step self-etch. But universal adhesives are coming on the market. They promise a lot, and especially on those cavities that are not too deep and they have a lot of enamel, they will perform very well. Okay? And regarding the composites, in the beginning we had the microfilled composites, the hybrid and microhybrid composites. Today we have the nanohybrid composites and the nanofilled composites, and we have to understand the properties of these materials. Some of those materials, like the microfilled composites, they are very good for using, let's say, in the interior restorations for the last layer, because they polish very well and they retain that polish for the longer period. Okay, hybrids and microhybrids, they're very strong, such as nanohybrids and composites. But nanohybrids composites, they vary a lot, the formulation. So some of them, they polish well, some of them, they don't polish very well. I mean, at the moment that you finish them, they polish well. But then on the long term, sometimes they don't perform well. And the nanofilled composites, they're supposed to be, we have the true nanofilled composites from 3M, and then you have the super nanofilled composites from Tokuyama, and they perform well. They are resistant, and especially the 3M composites. I don't think that the Tokuyama are so resistant, but they have a very nice polishing, very, very nice polishing. So the problem is we have good composites on the market. They are not very different from what they were in the past regarding longevity. Okay, using the new composite is not better for the longevity because we have longevity, I'm going to show you, with these old composites. The thing is, we have to understand the clinical challenges that we face every day in material selection. So some cases like this one here, where the patient wants us to do a restoration in this central, which is a dark central, okay? Of course, the patient has other problems. If we can imagine, we could suggest for this patient to do, let's say, 12 veneers, like you see here, okay? You can suggest that to the patient. I don't think that's what the patient wants, because actually what the patient asked me, she said, no, I don't want that. I have one problem. I have one dark tooth. I want you to solve that for me. So in order for us to do this restoration of one dark tooth, especially because our challenge here is not just to cover up that restoration. It's not that. We have to cover that up, and we also have to reproduce all these characterizations that the other central have. All these characterizations, you know, these areas of low values, like you see here, you see a crack here, you see some white stains, you see some brown stains here, some gray, dark stains. So these areas, all these characteristics, we have to reproduce on the other tooth in order for that to look fine. It's very challenging. Even if you say, oh, I'm going to, you know, just prepare the other tooth and send it to the lab, even though it's very hard. Because once you cement it, you might have a turn down effect. You might not have the effect you wanted, and once it's cemented, once you have polymerized the cement, if that doesn't look properly, and you're only going to see that in 1 or 2 days after the other tooth that was desiccated have been rehydrated. So then if you don't like it, you have to do it all over again. But with composites, if you don't like it, you can just fix it a little bit. You can just do a repair. You can just do some minor retouches. Okay, so here, in order for us to do this restoration, of course, we need to do some preparation. Okay, I like to preserve sound dental structure, but it's impossible to do the restoration in this tooth because the two centers are exactly at the same level. Okay, they're at the same level. So I need some space to block the dark tooth and also to reproduce all those characteristics that the other tooth has. So I need to do a preparation, and here I have a challenge because I need space, but I want to preserve as well as I can the most quantity of sound enamel from this patient, because we know that the more enamel we have on the tooth, the longer this restoration will last, because adhesive on enamel performs better than adhesive on dentin. Okay, so we're doing like a veneer preparation, the same way as we do it for ceramic veneers, without reducing the incisal edge. Okay, of course, here I see that at the incisal, I still have a very thick layer of enamel, so I'm going to reduce that a little bit more so that I can have more space and still have enamel to bond to it. Okay, so this is my preparation done, and now I'm going to start the restoration. And here is the challenge. After doing the adhesive placement, after we do that, we need to block that dark tooth. I'm going to use, in this case, the Empress. Let me slow this down a little bit. Let me show you here. I'm going to use this product, Empress Direct Opaque. And then I really like to use that. You're going to see that you sprinkle it on the tooth. It's not just a layer, a very, nice layer. No, you just sprinkle it. And then I'm going to use 2 shades of dentin. Okay, a darker dentin on the cervical, and then the other dentin on the medium and incisal thirds. Then I'm going to use my last layer composite, which is going to be the Renamel which has a very, very, very nice polishing and lasts for a very long time. I'm going to show you some old cases later. So I'm going to do the mesial and the distal walls first as a preparation for the restoration. Okay, so I'm doing the mesial wall, the distal wall. I'm going to do the cervical area. In this case here, I didn't use the rubber dam because the gum of the patient was very healthy. I just put a retractive cord on the gum just to control the fluids, and then I use it cheek and lip retractors. And now, as I use the microscope for everything that I do, because what you see here in this film is what I'm seeing while I'm working through the microscope. And this yellow shade that you see is a filter that the microscope has, because the light of the microscope is so strong that if I don't use this filter, I can't manipulate the composites because they will polymerize immediately. Okay, so what you see here is exactly what I see while I'm working. This is not a camera that is on the side of what I'm doing. No, this is a camera attached to the microscope that is recording exactly what I'm doing. Okay, so I can see here if I have anything from the gum that may compromise my restoration, blood, saliva, or fluid. Okay, so I can see it because of the magnification level that I'm working at. But if you have any doubts about that, use the rubber dam. Sometimes we use the rubber dam. Whenever we have a doubt that we can't control properly the fluids from the gum, or if the gum is not healthy enough, we always use the rubber dam. Okay, so let's go on. And I'm using some tints here, okay, blue and white, just to do the proper characteristics. Then I'm going to use, again, the Renamel A1, okay? I'm going to do that mark over there just to reproduce the crack that the other tooth has. Then I put a little bit of white tint. What I do here is this, okay? I put one layer of chromatic enamel A1 from Renamel. Okay, I established some spaces, because on top of that I'm going to use a achromatic enamel, which means an enamel composite without color, just for reducing the value a little bit. Okay, so now at this chromatic enamel, I'm creating some spaces where I want that stain, that dark stain that I put it, to be more relevant. And then with a mylar strip, I'm doing like a cut on the composite. I'm going to polymerize it, and then after that I'm going to put a little bit of white stain. Okay, then I'm going to remove it, just leave it just a little, polymerize, and then I'm going to use the Incisal from Renamel, which is an achromatic enamel. Okay, after doing that, I'm doing all the finishing and polishing, and this is the final restoration. At the moment that I finish it, this is immediately after I finish it, and this is a week later. Okay, after that, the patient didn't like this, the gum levels from what she was seeing. Okay, she didn't enjoy it. So, but if we're going to do a very big gingivectomy on the right side here, just to match the other side, because the patient didn't want to do a graft at this side, which she should, but she didn't want to do it. But if I'm going to do that, what's going to happen is that I'm going to expose, the dentin from the root of those tooths, and they will have to be restored, and those tooth will be restored for the rest of this patient's life. So we don't need that. Those two teeth, they are intact, completely intact. So what I did here is just respecting, the sulcus, respecting the sulcus, and using a diode laser, I just did a minor gingivoplasty, gingivectomy, a minor gingivectomy over there, just within the limits of the gingival sulcus, just that. Okay, you could do that with an electric You could do that with scalpel, electric scalpel, you know, electrosurge, but I really like to use the laser for that because I have a very nice result, and this is the final restoration. So everything I did here was to close the diastema in the right central and do a veneer on the left central. All the other teeth of the patient is intact. Okay? Of course, this is if you think here, you know, this is the most complicated restoration that you can build in a patient's mouth with composite presence. Okay, it can't be more complicated than that, probably. Okay, and you're going to tell me, oh, but that takes too long. It doesn't. It's an hour and a half to do that. Okay, if you're going to make an impression, if you're going to send to the lab, and then if you're going to cement it, and if it doesn't look good, you have to remove everything. So I don't think that doing that with a ceramic will be easier. I don't think so. And if you don't like anything on the restoration, you are able to fix it a little bit. Okay? So, as I said before, you don't need to do that. We have today some simplified shade composites, such as the FieldTech Universal, which I like very much, which is like a body shade. Okay, it's not as translucent as the enamel shade composite. It's not as opaque as the dentin shade composites, but they are in the middle way. They are like a body composite. And in some cases, like this one here, you can use just that composite. Here I'm using the BioClear matrices. Okay, I'm doing the injection molding, which is a very nice and interesting restorative procedure. That's probably going to be in one of my next videos. And here I'm using, with the injection molding, I'm using a flowable composite, okay? I'm not polymerizing that flowable composite, and then I'm injecting that FieldTech Universal, a heated FieldTech Universal composite over that flowable composite that I used, okay? So it's just one shade of composite, and this is the final result. That's it, okay? And here it's using just one composite. So in the other case, I use many materials, and here I use just the adhesive and two composites, okay? The flowable, but flowable is just to wet the cavity a little bit, okay? Just to create an easier mean for the composite, for the more bulk composite to penetrate inside those cavities. So you have to understand your composites, and then you have to choose them wisely. After that, we have the other risk factor, which is the tooth at the patient, okay? And we know that, okay, the size of the cavity or the restoration and the presence of endodontic treatment is very important when we talk about the longevity of restorations, because we know that smaller restorations, okay, small cavities will last longer than large restorations and large cavity. And the endodontic treatment is a factor that may, depending on the case, may compromise the longevity of a restoration. So cases like this one here, okay, where you have almost no enamel, you have endodontic treatment, a lot of dentin, a very large restoration, doing a composite here probably is not a good idea. Probably the best idea here is to do a full crown. So this is a work from Burke where his analysis confirms that larger restorations of all types, anterior and posteriors, okay, in all types of teeth, generally performed less well than smaller restorations, okay? This is very important. And regarding the patients, we have to understand that some patients are more susceptible to caries than others. Some patients, depending on their diet, will have an impact on the longevity also of their restorations. And also, if the patient has bruxism, if he's a clincher, okay, all these conditions all these conditions, they have a very important impact on the longevity of composite restorations, such as also such as age, because younger patients and older patients, they have more incident of failures than other patients, okay? And finally, the tooth position. And I don't mean if it's anterior or posterior tooth, but if the tooth is crowded, if the tooth is more lingually placed, okay? So the position of the tooth on the arch may have an impact on the longevity of the composite restorations. And also we have another problem, which is the personal preferences of the patient. Sometimes the patient comes to you and they want something that they don't need. They want a very white teeth. They have a perfect fine teeth, whatever, one or many. But they want a very bright and white, 12 veneers, 20 veneers, 10 in the upper arch, 10 in the lower arch, and sometimes it's hard to explain to the patient that they don't need it. And sometimes they get information, from Instagram, from Facebook. And, we have good things on Instagram and Facebook, but we have a lot of things that are not true, And restorations, another problem, restorations that last, that they are seeing, that were just made like a week ago, okay? They don't know how that's going to look within 5 years, within 10 years, within 20 years. Okay? They're not going to look the same thing. This is a patient that came to me, and she was going to remove the braces, and then I told her, let's do a little gingivectomy, let's do some bleaching, minor, composite additions at some point, just to make those laterals a little bit longer, just a few things like that. I think she didn't like my idea, but after a year, she came to me like this. She did, composite veneers all from second premolar to second premolar, okay? 10 composite veneers. The patient is 18 years old. She's going to have those restorations for the rest of her life. And trust me, they're going to stain, they're going to have minor fractures, they're going not to look very well, because they don't look well right now. So, she created a problem to herself, a problem that she didn't need it actually, but she thought that's what she wants. So cases like this one here, where you have one problem or minor problems, okay? Like 1, 2, 3 tooth, or just, closing some diastemas, in these cases you can use, small increments, small restorations, and they will last longer. They will be better for the patient. It's in the greatest interest of the patient if we do it properly. Small restorations. Even in case like this one here, in the bottom right, okay? Even those restorations, I don't have to put a composite over the whole tooth. No, just make small increments, just where it's needed, okay? And you can have a good result, a good ending result. And this is something that we need to do. This is the final factor that has the greatest influence in the longevity of restorations. Us, the dentists, okay? Our technical background, our professional experience, our treatment philosophy. If we are capable to do a correct diagnosis on the restorations, on the cavity, on the caries, if that restoration really needs to be replaced, this is our responsibility, okay? And if we're capable to do a very sharp technique, a proper operatory technique, a very conservative but very correct operatory technique, okay? This is again our paper, the paper that we did, and here we have some final conclusions, such as that the dentists and their decisions may also play a significant role in the clinical performance of the restoration, because in general the longevity of restorations would be longer if dentists were to use a more conservative approach when dealing with aging restorations, and avoided over-treatment by respecting the aged appearance of restoration in service, because sometimes restoration doesn't look, beautiful as they looked when you just finish it, and they won't. But if the patient is satisfied, that's okay. Take a look at this situation here. This is a case that we did, some class 3, class 4 restorations. We did some bleaching on the patient. This is the final result. We did that in 2004. Okay, this is the patient 16 years later. She had the diastema, but that didn't bother the patient. She was okay. Restorations were fine. I didn't do anything in those 16 years because she's a dentist. She didn't come to my office anymore. But what I want to show you here, so, you can say, oh, let's repolish. They're fine. You can do a minor repolishing after 16 years. It's okay. After 5 years, it's okay. But what I want to show you is, it's not my restorations. I want to show you this restoration here that she had in 2004, that we were going to change because I thought this here was a caries that was beginning like a microinfiltration, but 16 years later, it's the same thing. This is not caries. This is a staining. I don't mean that you don't have to change that, but patient didn't want to change. She's a dentist, said, no, it's okay, leave it. And I left it. Okay, so the presence of marginal pigmentation, classified by many as microinfiltration, is not enough for a secondary caries diagnosis. Okay, and here we left that, and 2 years later, 18 years later, they still look the same. We can do that, but the patient doesn't want to. And so why would I do that? They have been functioning for certainly over 20 years, because I don't know when that restoration, the patient doesn't remember when that restoration was made. Okay? So here, 18 years in function. This is a case we did in 97. Okay? We did two occlusal restorations, small restorations. Okay? This is the final case when we finish it. And this is 21 years later. We have some staining here, you see? Minor staining. They're going to say, oh, let's repolish. No, let's not do anything. Don't do anything. Look at here, 25 years later. Same thing. Don't do anything. Unless you really need to. Here's a larger restoration, a class 2 restoration, okay, that we did in 1997 also. You see, there's a crack there. I didn't do anything with the crack, just restored, okay? Just restored. And this is the case 21 years after. And here, 25 years after. If you take a look at the radiography here, they're fine. You have no problem here. This is the cracked tooth, 25 years later. Okay, this is the same patient on the other side. This tooth here, the first molar, is 21 years old. Okay, and here, 25 years in function. 25 years. Okay, this is a paper from a friend of mine, Paulo Rodolfo, and also the faculty from the Federal University of Pelotas in Brazil, where they have where they study the clinical performance of posterior resin composite restoration after 33 years. 33 years. And you see that clearly aged restorations with signs such as marginal and superficial stains, wear, chipping, changes in anatomical shape and translucent were still clinically satisfactory. They don't look nice because they are 33 years old. They don't look nice. They won't look nice. Even amalgam restorations after 30 years, they don't look nice. But they're still working. Repair, and also repair is something that you may and you should do as a first intervention option rather than replacement, resulting in greater longevity. This is a case here that we did in 1992. This is after 10 years, after 20 years, after 28 years, and after 30 years. They're still fine. But not all restorations perform like that because we have the other factors that we discussed before, okay? So this is another restoration that I did in 1992. Okay, this is after 10 years, this is after 18 years, and this is after 28 years. After 28 years, I was wondering, let's do something here. I think it's time, so we can replace it, but I didn't do anything because the patient didn't want to do anything at the time. That was two years ago. Okay, and now she came back 2 years later, so this restoration is 30 years old, but some other dentist, tried to change just a part of this restoration. This other restoration is 22 years in function. I'm not going to do anything with it for now. But look at here. Look how The other dentist replaced the restoration. This is how the restoration looks like from this part of the restoration on the right side of the first molar. That restoration is 30 years old. This restoration here is less than 2 years old. So sometimes you want to do something good to the patient and you don't provide that. This is also another restoration from 1992. Okay, this is 5 years after, 10 years after, and here 30 years after without doing anything. But here, the first molar is 30 years old, the second molar 20 years old, and here you see you have a very large caries here. Here in the first molar, the second molar, in the mesial and the distal. And she had, we went through the pandemics, and she was very depressed. She couldn't brush her teeth properly. She had, a plaque all over. She had other caries, anterior caries. She was in a very bad shape. But we managed it, to just do another direct composite. Okay, 30 years later, we did another. We didn't do even a crown. We did another composite. And now the patient here, she is almost 60 years old. And she still has, composite restorations in her mouth. You see? This is an anterior case that we did in 1998. Okay, the patient came after 11 years. We did some polishing, some cleaning, and then that was 11 years. This is 14 years, 16 years, 18 years, 20 years later. 20 years later, 21 years later, 22 years later. But now, 22 years later, okay, in function, we have, a minor crack, a minor wear, chipping, a minor chipping, in that tooth. Okay, what do we do now? Can we replace those restorations with ceramic veneers? Yes, we can do that. Of course, the patient now is almost 40 years old. We could do that. But then we ask the patient, what do you want to do? He said, no, just fix that. And that's what we did. We did a minor adjustment. We just added a little bit of, you see here, I didn't cover the whole tooth with my restoration 22 years ago. You see, here is the intact tooth of the patient. Here is the old restoration, very old restoration, 22-year-old restoration. And now here, I did just a minor repair. Okay, minor repair. And here, 22 years. And 24 years. 24 years. This is the story of an anterior restoration. Okay? Repairs, as this paper from Kenzel, repairs are a suitable treatment to increase the survival of restoration, even after previous repairs and replacements. So there is not a limit for how much repair you can do in a restoration. That's the beauty of the composite restorations, okay? And another interesting thing is that the longevity of repair restoration is comparable to restorations that have never been replaced. This is another case that we did in 98, okay? We did in 98, the patient came 11 years later, but it didn't age well, not as well as the other case. But the patient didn't want to do anything. Actually, here we were more concerned about her gums. It was very, it didn't look nice, it was very inflamed. So we tried to focus on that. And then she came after 5 years, okay? So this is 16 years later. It doesn't look nice. The laterals look nice. The canines are okay, but the tooth number 8 doesn't look nice. And she had a repair in this area here by a colleague. She's a dentist now, She's a dentist now. And this is after 21 years. And now, 21 years later, she wants to replace those restorations. And then we're going to replace with ceramics, why not? But not ceramics in all those teeth, because she didn't want any preparation on the canines, okay? So we removed the composites, which is a very difficult task if you want to make sure that you are going to preserve the sound tooth structure from the patient, okay? It's very difficult. It's not easy. People say, it's easy to remove composite. No, it's not easy. You can be more conservative than removing a ceramic, but it's a hard job, but it's okay. See, that's the tooth of the patient, in 1998, and now after we removed all the restorations, okay? So they still look fine. It looks pretty much the same 21 years later. And here we're doing, we took the impression, we prepared those teeth. The preparation was almost not necessary or anything. And then we cemented those veneers. That's what we did. You see here? This is the final case, ceramics and composites, okay? Ceramics and composites. This is another case that we did in 2003, okay? The patient came after almost 17 years, now 16 years later, 16 and a half. And, she has some staining or something, and then what do we do? What we do is that we ask to the patient, I'm saying here, it is in Portuguese, I say, Claudia, what do you think of these restorations that I did to you 16 years ago? Is it okay? She said, yeah, it's okay. Do you have any problem with that? No, it's perfect. I'm okay. Thank you. You're welcome. Okay, that's our conversation. So what did I do? I just repolish it. That's it. Okay? This is a case that I did in 2001. Okay, this is 18 years later. Okay? It doesn't look very good, but the patient was okay with it. I just repolish it. Okay? And then after 3 more years, 25 years. Right? 24 years. Sorry, 21 years. sorry. Sorry about my math. I'm not good at that. Okay, so after 21 years, it's still okay. You can say, oh, her gum levels are not the same. It doesn't bother her. Even though she has a gummy smile, it doesn't bother her. Okay, I'm not going to create a problem. This is a case that we replaced an adaptive restoration with herculite and renamel. And after 17 years, it also doesn't look nice. But the patient was going through a health condition. She couldn't do the treatment at that time. So what I did, I just repolish it. A very strong repolishing. And this is the result 17 years later. I still have some, low value effect here that I don't like. I could do something here, but this is a 17-year-old restoration. I'd rather not do anything for now. You see? And the patient was fine. And here, 3 years later, she still likes it. She still likes it. Here after repolishing. You see? So the longevity depends on several factors. And how can we avoid them? Doing a correct diagnosis. When to use the composite restoration, but especially when should I replace an existing composite restoration, either in the anterior section or the posterior section. Try to understand the materials you're going to use. Practice on a model. Practice with new composites. Try to understand which results you're going to obtain with the composite that you're choosing with. Okay? So this is a lifelong study that you have to do, and it's very interesting. But select properly the materials you have to use. Okay? Isolate the operating field properly. This is a restoration that is being done in a third upper molar. You can't isolate that properly, without a rubber dam. You need a rubber dam. You don't need a rubber dam in all cases, but for posteriors, I think all cases need a rubber dam. For anteriors, some cases might need it, some cases might not. Okay? But isolating properly is very important. And another very, very important thing is use correctly your adhesive. Okay? Do the correct use. Select properly the adhesive you're going to use and use it correctly. Read the directions that come with the product. Do a thoroughly polymerization, photopolymerization with a very good appliance, with a very good curing light. Okay, you need a very strong and consistent curing light, very important, such as Helipar from 3M, such as Velo from Ultradent, such as Blueface from Ivoclar. Okay, so use, it's not because you see a blue light coming out of your curing light that this curing light is curing properly your restoration. So you have to cure it thoroughly and properly. Okay, polish your restoration. Polish thoroughly when you finish it. Okay, go all the way. Go all the way, and don't keep repolishing every time that you see the patient. Okay, I see on Instagram and Facebook people saying that you have to repolish a restoration every 6 months. I mean, my God, don't do that. If you repolish a restoration every 6 months, the restoration won't last. Okay, you do it whenever it's needed, but usually every 2-3 years. That's okay. Okay, whenever needed. Okay. Check the occlusion. This is very important, very important. Some restorations don't last because they're unbalanced, because the occlusion is unbalanced. Okay, check the occlusion, do it properly, and do your operative procedures with precision. Okay, be precise in everything you do. And to be precise, operative and motor precision, you can only do it with optimal visualization. So try, if you don't use it, try to use a loop or a microscope in your procedures. We're going to be talking about that later on, okay? Thank you for watching. See you next time.